So I see many familiar faces in the audience. Thank you for coming and being here on a Saturday. And what else could be better than listening to genetics on a Saturday morning, right? So I have the task of keeping you all interested, awake, and I'll do my best to keep you informed too as well with genetics. And you've already heard from Dr. Kumar that we really think this is very, very important. And as you know, we interact in the clinic. As many of you know, we have this in the background of our heads as we think, okay, what might be the next best treatment, and how does that information fit into the next decisions we might be making for the management of your myeloma. What I'm going to tell you first, everything I'm going to talk about genetics right now is about genetics that has changed since you were born. So we're not talking about anything that's genetic that you're going to pass on from generation to generation. And this is really critically important. Everything I'm going to tell you is restricted to the myeloma cells. So if we were to take a biopsy, say from skin or from other parts of your body, you're not going to see this. This is just something that exists in the myeloma cells. And this is an important point because one might worry, is that part something that perhaps my kids will get? And the answer is no. There are some items that need to be discussed with myeloma genetics as it relates to heredity. But most of what we talk about is the changes that occur in the myeloma cells. So I make that point as a very, very important one when we think about this genetics. So let's talk a little bit about genetics. So first of all, this is how cells look like. This is just a very crude picture of a cell. They look like little eggs, and the eggs are of different shapes and sizes. These are what we call epithelial cells. But what they have is a big circle, which is a cytoplasm. And at the center, you always see a collection that we call the nucleus. And these ones look actually rather small. I'm going to show you some actual myeloma cells later. Now, the nucleus is really the brain of the cell because that's where all the DNA is contained, and that's where all the information and messages and signals go out so that the cell knows what to do. And what it contains is what we call the DNA. And again, I'm going to break this down further. Think of the DNA as the alphabet from which we make words and we make sentences, we make paragraphs. That's what the DNA is. The DNA just contains the information that our bodies need to build everything it needs to build, and predominantly, proteins, and that's how our bodies are built. So if you're a brain cell, you need certain types of proteins that are going to be important to form memories, to know how to create neurons. If you're a liver cell, you need to activate that part of the DNA that it's important to create those proteins that are important for the liver. So the DNA is really the repository of all of our body's information, and in one cell, in the nucleus of one cell, you have all the information you need to build a whole body. That's kind of the interesting part and the beauty of the DNA. And you should know that DNA is shared by all species. The same code is shared by us, by snails, by fish, by dogs. Every species has the same exact code. And when you put the letters in the right order, like you do with let's say with the alphabet, you get the right message. So that's what DNA is. Now, this DNA comes in a string. So think of the DNA as a very, very long string. It turns out that string mostly contains nonsense, contains noise. Every now and then in that string you go noise, 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 and there's a series of letters that tell you a word. And that's what we call genes. Whenever you start seeing words, that's what we call genes. But at least 90% of our DNA is just junk. There's background noise and it means nothing. So there's just certain fragments where genes come through. And what you were hearing from Dr. Kumar is when that DNA gets disrupted because you chop a little bit of it or because maybe you create a typo, then that's when the message can go wrong. And that's what leads to the vast majority of human cancer is mistakes in that DNA. And this is how it looks like. It's kind of we call it a double-stranded. It looks like a ladder that you could twist. And each one of those little sticks here would be one of the letters for the message that comes out of the DNA. Now, if it was in a string, as you can imagine, that little nucleus that I showed you would all be a mess, right? So it has to be compacted into structures that we call chromosomes. So chromosome is just a compacted structure that contains the DNA. So if you look at that same cell again, you see the chromosomes, then you start going deeper with a microscope, you see that each one of the structures that we call chromosomes is just a tightly packed string of DNA. And it has a lot of structures, not only this, but it goes into circles, and there's little proteins that are attached to it. So the actual string itself is very deeply buried into that chromosome. And when cells need to send a message, so let's say you need to send a message that tells a cell, repair, you have been damaged. Let's say that's a message. The cell will open up the string in that area that sends the message, repair, you have been damaged, and the message goes out. And that's how the DNA works. And once that's done, it compacts back again. So that's how DNA works. So you think of it as a spool, as a thread spool. That's how you can think of the DNA, and the spools are the chromosomes. And in fact, as you heard from Dr. Kumar, we have 23 pairs of the spools. And then, you get half of your DNA material from mom and half from dad. And that's why, we have that resemblance, of course, to the family. And we actually just count them. We count them chromosomes 1, 2, 3, 4, 5, etc. At the very end, you have just a separate set of options. So if you have 2 of the X's, as you know, you're a woman. If you have an X and a Y, then you're a man. So that's those are the determinants of how we're made into men and women. And this is how normal chromosomes would look like. Now, this actually looks just like that. This is actually a real picture of chromosomes. So people can actually use very fancy dyes to look at the chromosomes. And what you see there is the spools that I showed you in the previous pictures. That's how they are. So then they come out here with a software program. They cut them out and they align them just like Dr. Kumar showed you. And this is, again, these are real chromosomes. And there's ways you can paint them in different ways so people can read out. And they say, well, yeah, that has 22 chromosome pairs that are normal and 2 X's. So this is a woman that seems to have a normal chromosome content. So we want all the cells in our body to look like this. That's order, is discipline, there's no mistakes. Cancer, and myeloma is no exception, is when there's hiccups in this process. When something happens in this process that the cells, that you have a cell that decides to divide and then it divides but it creates a problem. Now there's one that is effective. Now, fortunately, the great majority of time, our body doesn't allow that. Our body is very unforgiving for DNA mistakes. So if that happens, that cell dies and it's removed. But, just like even if you're a great teacher and you're proofing the writings of your students, every now and then something will go through. And that's what leads to cancer, and that's what leads to myeloma. So these are good spools. Now, these are bad spools. This is another picture of chromosomes. I just made it a little bit more flat. But what you can see here is that we're starting to see a bunch of genetic changes. So for instance, this cell, this pair of chromosomes, chromosome 7, which should look pink, now have a little extra hat here that comes from somewhere else, and it turns out it comes from chromosome 7, and from chromosome 12. So chromosome 12 and chromosome 7 exchange a little pair. They change hats, if you may. And that's what we call a translocation. And that's very important, of course, because that's what leads to cancer. Now, Dr. Kumar told you also about deletion. So looking now at this chromosome 8 here, chromosome 8 is missing a big part. And that's what we would call large deletion. And those are some of the things. And then another example, you have chromosome 21. You have an extra copy of chromosome 21. And I'm sure many of you in the audience are going to think, chromosome 21, what do we know about chromosome 21? So people who have Down syndrome are born with an extra copy of chromosome 21. And if you were to do the same test on someone who has Down syndrome, this is what you would see. And in fact, this is a karyotype of someone who has Down syndrome who develops leukemia. So that's kind of how we look at chromosomes. Now, this is a very crude view. This is kind of if you're taking, a satellite from space and you're trying to define, what a country looks like or what a region looks like. Fortunately, we have very high resolution tools that we can go deep down, and then we're going to be looking and we're going to be asking about the words, their meaning, typos, etc. I'm going to tell you about that. Okay, so this is a myeloma cell. So the myeloma cells, I always describe them as fried eggs here. You see it has a larger nucleus than the cell I showed you before. And this is myeloid cells. So these are the cells that give rise to your neutrophils. And for many of you who've gone through transplant, you know that we pay a lot of attention to those. Those are the normal infection-fighting white cells. What I've done here, we applied 2 FISH probes. So you see there's 2 green signals and 2 red signals. And with what you know now, let's just put things together. First of all, these probes detect chromosomes. And I would expect to see 2 signals. These probes go and bind to a specific region of a chromosome. So there's 2 signals here and 2 signals there. So that tells me that the question I'm asking with FISH is that the answer is normal. This person has 2 copies of the chromosomes as we're expecting. FISH stands for, it's kind of a mouthful, but it's fluorescent in situ hybridization. And it just speaks to this laboratory technique where we actually see these fluorescent signals. If you see this in a microscope, it's actually it's a beautiful thing. It almost looks like a Christmas tree. It's very bright. You're looking through a microscope, you see all these lights shining back at you. And then we count them. And if this myeloma person, if we had used probes, say, for chromosome 13, and I only see one red signal, I would say this person has deletion of chromosome 13. That's how we test for that. Now, the things we are most interested are, for instance, translocation. So we can put probes that go to those hats that I show you in those spools, those metaphases that we call. And if they suddenly come up together in our imaging, we say, that's abnormal, that's a translocation. So if you have an 1114 or a 414, we would have seen that through the FISH testing. Or if one of the ones we're most concerned about is deletion of 17. If you had deletion of 17, let's say this red probe was 17, what that would mean is that we would only see one of those reds because the other one is missing. So when we see our reports and we put in the medical record, would say deletion 17, that's what we would be seeing in that FISH reports. I'm going to tell you a little bit about how we classify myeloma, and Dr. Kumar already alluded to this. There's many ways to classify it. At the end of the day, every single myeloma is different. So every classification I show you is kind of just broad brushstrokes of what we may consider, but at the end of the day, every myeloma is different. But what do we know? First of all, we break it almost in half in those that have translocations, remember those that change the hats, versus those that have extra copies of chromosomes. And we use a mouthful, hyperdiploid. Now this is important because the work of several groups, including a very important work from Dr. Kumar, has shown that hyperdiploid is a little bit different. Hyperdiploid tends to be a little bit more of a stubborn myeloma. It's kind of like a bad guest that stays for dinner for too long. It comes slowly, but it doesn't leave the house, and that's how hyperdiploid behaves. Sometimes we have a hard time completely eradicating cells that are hyperdiploid, but then they may stay in the background and be somewhat indolent or hibernating, if you may. On the other hand, those that have translocations, in general, and again, nothing of this is absolute, tend to be more aggressive and tend to be more with cancer-like behavior. If you actually look at clinical features and age, this is how this breaks down. So there is a benefit of being older in myeloma, because if you're younger, you're more likely to have more aggressive myeloma. Patients who are younger are, and this is not absolute again, but are enriched for patients who have high-risk genetics. Interestingly, they sometimes have no evidence of bone lesions. So younger patients who have very aggressive myeloma can sometimes present without bone lesions. And in general, and this is, again, not absolute, but if we see a myeloma patient who's IgA or lambda, that raises a little bit of our awareness or our concern for this being more high risk. On the other hand, again, advancing age being a factor here that's positive. The myeloma patient that we all read about in a textbook is usually more the elderly person, has this hyperdiploidy, usually has bone disease, and it's more the typical IgG kappa form of multiple myeloma. And as Dr. Kumar and I see patients, this is very, very important because we integrate all of this as we're thinking about, what should we do about choice for treatment for the condition. Now, these translocations, we have both told you about, have an interesting feature. These translocations, what they do is when you change hats, imagine it's a magical hat, and one of the hats makes the other chromosome start saying things it shouldn't be saying. That's what translocations do. Okay, so what they do is you put that little fragment of that chromosome, and you'll meet Dr. Bersago, who's going to be coming in here soon, but he and his wife, Martha Kesey, who's also a research scientist, they both discovered a number of translocations that we didn't know about in multiple myeloma. So they did the seminal work for that. And because of that, now we know what they mean in the clinic, which is some of the work we have done. But so you think of it like a magical hat. You put it now in the new chromosome, and the chromosome starts speaking and starts saying things it shouldn't be saying. So there's one translocation between chromosomes 11 and 14. And there's this gene called cyclin D1 that is expressed. Now, just on this one, trust me, if this is brown or this is dark, that means there's a lot of cyclin D1 message. It's another technique we're using. So if I see this and a pathologist tell me, hey, I did a stain for the cyclin D1 and it's positive, immediately I'm going to think this person probably has an 11-14 translocation, and this is what we would see. And that's what makes them again, become cancer. When you have a translocation and you start saying things you shouldn't be saying, then the cells can do a number of things, including they start dividing, they start growing, they don't remain resting as they're supposed to be doing, and that's what, again, gives rise to the multiple myeloma. So what about importance in the clinic? I'm not going to belabor this too much because you've heard this from Dr. Kumar, but I'm going to compare myeloma to acute leukemia. So in the field of hematology and blood cancers, acute leukemia is a good example of how you can use genetics. Because what people have done, in leukemia is they break all the steps of the maturation of those neutrophils into a subtype of leukemia, and they have come up with this classifications that has 7 steps. And over the years, leukemia doctors have been able to use this to determine treatment. So there's a form of leukemia called M3, which turns out that it has a genetic change that responds quite well to the administration of substances that are related to vitamin A. So in fact, these people are highly curable. If you have this type of leukemia M3, they're highly curable. Part of that is because of that genetic knowledge. Sometimes this information helps them think about prognosis and whether a person should get a stem cell transplant or not. Now in myeloma, it's a little bit different because myeloma comes from plasma cells. These are all the steps that B cell goes through maturation, and I won't go much into that, but the plasma cells are kind of the seniors in that process. The plasma cells are the very late stage B cells. Those are the ones that normally would protect our body, would give us immunity by forming antibodies. So instead of breaking all these B cells, it's a plasma cell that we break up into all these genetic subtypes, which again we will use to look at treatment. Now, you've heard from Dr. Kumar, these 3 markers historically had been considered high risk, but the good news is now that we know about them, some of them actually we have been able to reduce the risk. So the 414, for instance, which we used to think is a very high risk, still can be challenging, but if the person is treated with a type of drugs that we call the proteasome inhibitors, and that's the Velcade and the Ninlaros and carfilzomib, those are patients that actually will derive a lot of benefit from this. So in fact, so much so that these patients have moved into a much better prognosis category. But if your doctor doesn't know that and they don't think this person should be getting proteasome inhibitor, we can't do that. If you have a 414 or if you have a 17p deletion and you go through a stem cell transplant, the way we would think about your maintenance is different. For the vast majority of patients, and we'll talk more about this, the vast majority of patients who go through transplant and are going to get maintenance, usually the lenalidomide, the Revlimid alone is sufficient. But if you do have high-risk markers, what we're doing here in the clinic, we're adding Ninlaro to all those patients' regimens because it makes a difference in how we're able to control the disease afterwards. Now, some of this is recent information, so if someone in the audience is thinking, oh, well, I had a 414 and maybe had a transplant and I'm now getting Ninlaro, it's a little bit hard to go back and change things given what we know now, and there's a lot of options for treatment. But if a new patient comes to us right now and gets a transplant and has high-risk markers, we would usually do something like that. I'll skip this just in the interest. So why bother with genetics? So if you ask doctors, and this is beyond myeloma, if you ask doctors about a test, you say, should we do this test? The doctors are always going to respond, if I get a test result, what am I going to do different? That's a pretty standard kind of medical behavior. People will say, what will I do different if I have this test? So these are the things that I think are very important for genetics. First of all, counseling. Myeloma, we have greatly improved options for myeloma patients, and we have better treatments. We have 11 drugs approved. But if you have -17, we're going to be far more careful in how we think about putting a game plan for you. If you have hyperdiploid, we might say, well, maybe it's not going to go away altogether, but we have good options, and a lot of these patients can live for many, many years. So it's very, very important to have that transparent discussion with patients. Number 2 is treatment selection, and that's mostly in the form of the after-transplant treatment if you're a transplant candidate. However, if you're not a transplant candidate, if for some reason transplant is not part of your treatment, then also one should consider the use of these drugs that we call the proteasome inhibitors. And last but not least, I'll show you an example, is becoming predictive. Now, what I mean by predictive is if you have genetic information that would tell you if a drug is going to work or not. It's kind of having like your car. If your car is diesel and you put gas, it won't work. So diesel works with diesel, and that's what we mean by predictive, that you find information that's going to allow you to do the right thing. So one example, again, is this 1114. I mentioned this before. This 1114 translocation is actually seen in about 15% of patients. So 1 in 6 patients have this abnormality. And as I showed you before with the brown staining, you know, this is how it looks like. It's actually a very interesting translocation. This is something that is associated with other conditions. So patients with amyloidosis, I know some of you probably have met patients or have experienced this. About half of the patients with amyloidosis have the 1114. And one of the things that we have learned is for patients that have this abnormality, there's this new drug called venetoclax. Venetoclax is being used, and it's FDA approved for the use in chronic lymphocytic leukemia. It comes in a pill form. And for some patients where we may be exhausting options, sometimes we have treated with venetoclax. And these are 2 plots of the light chain. So I know you're familiar with Emma Kappa light chain on 2 patients. We start venetoclax. These are patients of Dr. Stewart in a clinical trial, and you see what happens. It drops down. Now, these results have been of enough importance to us that we always try to put our patients with 1114 or give them options through clinical trials. And if for whatever reason there's not a clinical trial, we have a system now to try to get the drug, what we call on a compassionate basis, from the company. That is not to say if you have 1114, we're not going to say right now, at least in October of 2017, we're not going to say, oh, you should skip the transplant or you should skip standard treatments. But if you've been through those and we need a new treatment options, we have one more tool in our toolbox. Okay, so that's for the 1114. Now, just very briefly, there's other ways in which you can determine risk. There's the so-called gene expression profiling. This is work that has been done by many groups, but the pioneers were investigators at the University of Arkansas, where they could use signatures. So now they look at 40,000, 50,000 genes at once. It's like asking 50,000 questions a person and then coming up with their personality. I think most psychologists would be quite confident they could do that if you could ask 50,000 questions. Well, we can do that with myeloma cells all at once. And actually, right now, it's for a cost of about $400. So that would be much cheaper than 50,000 questions from a psychologist. And it turns out that not only you can tell the personality, but you can tell the subtypes too as well. Well, it turns out, you have this personality traits, et cetera. So that's what people do with gene expression, and it's one of the other tools. And actually, people can get this through a commercial laboratory where you can get your results for patients. And it's not that both have to be done, but at least one of the tests, be that the FISH or the gene expression, should be done. Now, again, I was telling you, we're looking at Google Earth with the chromosomes. We get down with the FISH. We're down to the 10,000, 5,000 foot view. Now we're going to get the Google Street View, and that's what we're doing with the sequencing. And with the sequencing, what we're looking is for an Achilles heel of myeloma, something that is so clear, so crisp, that is essential for that cell survival that we can attack. And we talked about the translocations. We talked about the mutations. And this is an area that many of us are involved in, and several groups are doing research to see if we can understand how the genetic sequence can be used.